Hello. Hi. Good evening, everyone. This is Loshna, the Regional Business Manager for the Voluson products for Southeast Asia. Thank you all very much for joining us tonight on part 2 of the 6-part web series on fetal echo. Before we start the webinar, I would just like to remind everyone on some tips and tricks should you experience any connectivity issues during the webinar today. Please do join through the Adobe Connect app if you can. Otherwise, do double check your internet speed for connectivity strength, or do try to log out and log in again. On that note, I would like to invite Dr. Balu Vaidyanathan to get us started on tonight's topic, the abnormal 4-chamber view approach.
Good evening. I'm Dr. Balu Vaidyanathan from India. Welcome back to this fetal echocardiography webinar series organized by Voluson GE Asian segment. This is the second lecture of the series, and in this lecture we shall talk about the abnormalities of the 4-chamber view. The 4-chamber view is one of the easiest views to perform in fetal heart evaluation. This view can be performed in all settings, irrespective of the degree of expertise or the quality of the equipment, and hence this is ideally suited for mass screening programs. A large spectrum of abnormal hearts can be identified by using this view alone. The 4-chamber view also permits a quick assessment of the cardiac rhythm and cardiac function. And from a prognostic point of view, the 4-chamber view will help to separate the congenital heart defects which can undergo a complete correction versus the ones who can only be palliated and who need multiple operations. Typically, the correctable problems have an intact 4-chamber view with 2 good-sized ventricles, while the ones which are complex, which can only be palliated, typically have an abnormal 4-chamber view with hypoplasia of one or the other ventricle. So in my first lecture, we discussed the fetal heart segments, and we also spoke about a segmental approach to the fetal cardiac evaluation. Revising the fetal heart segment once again, we start the examination of the fetal heart with the abdominal situs. Then we move to the atria. These two together constitute the first segment called the visceroatrial segment. The systemic veins, or SV, they drain to the right-sided atrium, while the pulmonary veins drain to the left-sided atrium. So following the atrium, we have the next segment, which is the ventricles. So between the atria and the ventricles, we have a connecting segment, which is the atrioventricular junction. After the ventricles, we have the great arteries, and the next connecting segment between the ventricles and the great arteries is the ventriculo-arterial junction. Using the 4-chamber view, we can evaluate all but the final segment of the fetal heart. That is, we can look at the situs, the atria, the ventricles, and the atrioventricular junction. And we can also get clues towards abnormalities of the systemic veins and pulmonary veins. Hence, a large number of abnormalities of the fetal heart can be suspected or diagnosed by only the 4-chamber view. So let us revise the anatomy of the normal abdominal situs. The left and the right are marked here. The stomach, which is designated as ST in this picture, is on the left side. The liver is on the right side. The aorta, which is shown by the red circle, is to the left of the spine. The inferior vena cava, which is now shown by the blue circle, is to the right of the spine. It is important to understand the relationship between the aorta and the inferior vena cava. The inferior vena cava is anterior to the aorta, and it is to the right of the spine. Now, by looking at the position of the aorta and IVC in the abdomen, we can get valuable clues towards the possible variations in the situs. So this is one example. The left and the right are marked. The stomach, or ST, is on the left side. The midline is shown by this line. So when we look at the inferior vena cava, which is V, and the aorta, which is A, we can see that they are both on the same side of the spine. In this case, both of them are on the right side of the spine. This is referred to as the juxtaposition of the inferior vena cava and the aorta. Now, The relationship between the two structures is normal, that is, the vein is anterior to the aorta, but the difference is that both are on the same side. This is the hallmark of what is called right isomerism. Now, this is the second example. The left and the right is marked. The stomach is not clear. The aorta is shown by A, and anterior to the aorta, we don't find any venous structure. So, where the IVC should be, we don't see anything. In contrast, we see a venous structure posterior to the aorta. So, this is not the IVC, but this is rather the azygos vein. In this case, what has happened is the inferior vena cava is absent and the IVC is continuing as the azygos vein into the SVC. So this is referred to as the double vessel sign, and this is a characteristic feature of left isomerism. So by simply looking at the position of the aorta and the IVC in the abdominal situs, we get clues towards this diagnosis of complex hearts called isomeric hearts. These are not the only abnormalities found in these isomeric hearts. They have variations in the four-chamber view in the form of typically complex avic septal defects. Outflow tracts could be abnormal. The pulmonary venous connections could be abnormal. But the first clue for the diagnosis of these complex anomalies comes from evaluating the position of the aorta and the IVC in the abdominal situs. Now let us come to the four-chamber view itself. So in the normal four-chamber view, we understood the checklist in my last lecture. So we start with evaluation of the heart size, the cardiac axis, chamber symmetry between left and right can be noted. In this picture, we can see it's symmetric. The flap of the foramen ovale will point towards the left atrium. Pulmonary veins, as shown by the arrows, will be draining to the left atrium. The crux of the heart, where the septa and the AV valves join, should be intact. The moderator band is located in the right ventricle, and then we look for the area around the heart and area behind the heart. From the perspective of abnormalities, the four-chamber view can be actually evaluated from different segments. First, we start our examination with left heart and anomalies for that. Then we look for right heart abnormalities. Then we look for abnormalities of the septa and the crux of the heart. Then we can look for intracavitary lesions or changes inside the cavity of the heart. Look for abnormalities in the area around the heart, and finally look for variations in the area behind the heart. So we can classify four-chamber view abnormalities with respect to their location as follows. Left heart abnormalities, in which we will see three conditions in this lecture. Right heart abnormalities, again there are three common conditions. Septal defects in the crux of the heart, where we'll examine mostly AV septal defect. Then we also see examples of septal defects, ASD, BSD, and also an abnormality of the offsetting in corrected transposition of great arteries. Intracavitary lesions include tumors, diverticular, echogenic focus, and so on. For the area around the heart, you look for evidence of pericardial effusions or pleural effusions. For area behind the heart, you look for abnormal channels, additional vessels. Then the four-chamber view also gives clues to abnormal cardiac rhythm as well as abnormal contractility. There could be variations which are not included in this, but this kind of a systematic approach helps us to evaluate the four-chamber view in a comprehensive manner. First, let us look at the left heart abnormalities. The three conditions which I shall discuss under this spectrum include hypoplastic left heart syndrome and its variants, critical aortic stenosis, and asymmetry or disproportion of the left heart structures. So this is the first anomaly, hypoplastic left heart syndrome. The left and the right are marked. This is one of the most complex kind of congenital cardiac anomalies, and this is something which we can never afford to miss. The hallmark of hypoplastic left heart syndrome is the smallness of the left ventricle, as you can see here. The left ventricular length is extremely small, and if you measure the Z score, which we discussed in my last lecture, it will be often less than -3 or even smaller. Typically, we say that the left ventricle does not form the apex of the heart, as we can see in this picture. The right ventricle is normal size, and as we can see by the blue arrow, the right ventricle is forming the apex of the heart. This is showing color flow mapping in hypoplastic left heart syndrome. As we can see, there is no filling of the left ventricle. The entire blood from the left atrium cannot enter the left ventricle. That is because the mitral valve is completely shut or atretic. As a result, the whole blood from the left atrium will go across the foramen ovale to the right atrium and then to the right ventricle. Thus, the features of hypoplastic left heart syndrome in the four-chamber view include the small hypoplastic left ventricle, the apex is formed by the right ventricle, and there is complete left to right shunt of the left atrial blood to the right atrium through the foramen ovale. Now we will see one variation of the hypoplastic left heart syndrome with restriction of the foramen ovale. So here we can see the left ventricle is small, and when we look at the atrial septum, we can see that it is completely appears intact. There is no defect. And if we notice carefully, the foramen ovale is bulging towards the right atrium. When we look at the color flow of the pulmonary veins, as indicated by this arrow, the pulmonary veins are quite engorged. This is because there is no flow from left atrium to left ventricle because the mitral valve is atretic. So the only exit pathway for the blood reaching the left atrium was through the foramen ovale. And hence, when the foramen ovale is restrictive, the entire blood gets dammed inside the left atrium, causing high pressure of the left atrium. This is what is causing the bulging of foramen ovale as well as the dilatation of the pulmonary veins. So this can be evaluated by using pulmonary vein Doppler for the assessment of the hemodynamics. So in the normal pulmonary veins, when we put the Doppler, we see two positive waves, the S and the D waves, and a very small atrial reversal wave. This is because the left atrial pressure is normal here. In hypoplastic left heart syndrome with restrictive foramen ovale, the pulmonary vein pressure is increased because the left atrial pressure is increased. So when we do the pulmonary vein Doppler, we can see a very prominent atrial reversal wave. This is suggestive of high pressure in the pulmonary veins. So a very simple hemodynamic principle which is very clearly illustrated using the pulmonary vein Doppler. Now we go on to the second example in the left heart, which is critical aortic stenosis. So I'm playing this movie and we can see that the left ventricle, which is marked LV, is quite prominent, dilated. And in comparison to the right ventricle, the contractility of the left ventricle is significantly reduced. The initial assessment, one may say that there is a myocardial dysfunction alone, and people may write this as a diagnosis of cardiomyopathy. However, when we look at the left ventricular outflow in this picture, we can see that the aortic valve is quite thickened. And when we put color Doppler, we can see turbulent flow across the aortic valve. Thus, it confirms the diagnosis of aortic stenosis. So the cause of LV dysfunction is because of critical aortic stenosis. This is a variant form of critical aortic stenosis. Here we can see again the left ventricle is quite dilated. On the ventricular septal surface we see a white patch, which is because of endocardial fibroelastosis. The left atrium, LA, is also quite dilated, and here also we can see that the foramen ovale is bulging towards the right atrium. And when we put color Doppler, we can see that there is a significant regurgitation of the mitral valve. So this is a variation of critical aortic stenosis with severe MR, and the prognosis is quite suboptimal in this condition. People have attempted to salvage this kind of fetuses by doing an in utero balloon aortic valvuloplasty. We shall briefly discuss its role in my lecture on counseling, which is the fifth lecture of the series. The third abnormality of the left heart is ventricular disproportion or ventricular asymmetry. So when we look at this picture, the left ventricle is marked as LV. We can see that lengthwise the left ventricle is okay. It is reaching up till the apex of the heart. The length of the left ventricle and the right ventricle are almost comparable. However, when we look at the width, it is quite small. So this is a mitral valve, which is shown by the arrow, and we can see that the mitral valve is not opening very well, suggesting of congenital mitral valve stenosis. And when we look at the left ventricular outflow tract here, we can see that the entire left ventricular outflow tract appears quite narrow, suggesting obstruction. So a combination of small size LV, which is apex forming, mitral valve narrowing, left ventricular outflow obstruction, all these together constitute what is called significant ventricular disproportion, and sometimes we refer to this combination of findings as Schoen's complex. Now we move on to the right heart lesions, of which we have three important conditions: tricuspid valve abnormalities, which cause tricuspid regurgitation; hyperplastic right heart. Another name for this condition is pulmonary atresia with intact septum, and the third is tricuspid atresia. So the first is tricuspid valve lesions causing regurgitation. There are two conditions in this. One is Epstein's anomaly, and second is tricuspid valve dysplasia. So in the first look, both these hearts look extremely similar. The common features for both conditions is that there is significant cardiomegaly, particularly the right atrium is quite enlarged. And when we put color, there will be severe tricuspid regurgitation. But the differentiating point is that the level of insertion of the tricuspid valve is lower in Epstein's, while in tricuspid valve dysplasia is it at the normal level. So the anatomy of the tricuspid valve is illustrated here. So in Epstein's, the septal and the posterior leaflets are displaced inferiorly towards the apex of the right ventricle. So that is the displacement. And in the lower picture, we can see that we can even measure the level of displacement. The more the displacement, the more severe is the Epstein's. In tricuspid valve dysplasia, the leaflets will be inserting at the normal level of the tricuspid valve. So this downward displacement of the tricuspid valve in Epstein's is illustrated and compared with the tricuspid valve dysplasia in these pictures with 4D rendering. So in Epstein's anomaly, we can see that the tricuspid valve is inserting at a much lower level compared to the mitral valve, which is at the normal level. However, in tricuspid valve dysplasia, the tricuspid valve is at a normal level, which is slightly below the mitral valve because that's normal offsetting. So this is the first difference between Epstein's and tricuspid valve dysplasia. That is the downward displacement of the attachment of the tricuspid valve. Now let us look at the second difference, which is a TR jet on color. So if you notice this movie, you can see that in Epstein's anomaly, the tricuspid regurgitation jet is coming from the middle of the RV cavity. But in tricuspid valve dysplasia, the regurgitation is actually at the level of the tricuspid valve annulus itself. Finally, we look at the size of the right ventricle. In Epstein's anomaly, the right ventricle is divided into two parts: the true right ventricle, which is apically located, and the atrialized right ventricle due to the downward displacement of the septal tricuspid leaflet. So this is the true right ventricle, and this is the atrialized segment. So here we can see the atrialized segment nicely in the green box. That is due to the downward displacement of the tricuspid valve, while the true right ventricle is more apically located. In more severe forms of Epstein's, there will be more displacement and the right ventricle hence will be more small. However, in tricuspid valve dysplasia, the right ventricle is normal sized. So to summarize, the three differences between the tricuspid valve dysplasia and Epstein's are: one is the anatomy of the tricuspid valve, two is the level of origin of the TR jet, and three is the size of the right ventricular cavity. Now we move on to the next anomaly, which is pulmonary atresia with intact septum with hyperplastic right ventricle. So this is a four-chamber view of the same, showing a normal size LV, while the right ventricle is quite small. There is a large interatrial communication. This is shown in the 4D rendered, surface rendered picture. The cavity of the right ventricle is small. The tricuspid valve doesn't open very well, and there is a large interatrial communication. Now this is a variant of pulmonary atresia with intact septum with hyperplastic RV, where the foramen ovale is restricted. So we can see in this picture that the RV cavity is quite small, while LV is normal sized. When we look at the foramen ovale, we can see that it is bulging. And the same is shown in a very beautiful depiction with 4D rendering. An extremely small RV cavity, and the LV is good sized, and we can see the bulging of the foramen ovale. Here, the hemodynamics is that the blood cannot easily enter the right ventricle because the tricuspid valve is small. So the entire blood in the right atrium has only one exit pathway, which is the foramen ovale. If the foramen ovale is restrictive, the right atrial pressure will increase, and this will cause bulging of the foramen ovale. This is similar to the hyperplastic left heart with restrictive foramen ovale, where the left atrial pressure will be elevated. Just like we use the pulmonary vein Doppler to evaluate the hemodynamics in HLH, we can use the ductus venosus Doppler to evaluate the hemodynamics of restrictive foramen ovale in pulmonary atresia with intact septum. So in the normal ductus venosus Doppler, we have two positive deflections S and D with a small atrial reversal wave, A wave. However, when there is a restrictive foramen ovale in the setting of a right heart abnormality, the right atrial pressure will be elevated, and thus there is a very prominent A wave reversal in the ductus venosus Doppler. So this is highlighted in this picture. The last abnormality of the right heart which I would like to discuss is tricuspid atresia. Now this picture is showing all the characteristic features of tricuspid atresia. The right ventricle is small compared to the normal size LV. The tricuspid valve is completely atretic and not opening. There is a ventricular septal defect shown by the star, and there is a large interatrial communication. When we look at the color flow mapping of the same, we can see that the right atrial blood does not enter the right ventricle because the tricuspid valve is completely atretic. Instead, the right atrial blood will go to the left atrium through the foramen ovale. And then from the left atrium, the blood will enter the left ventricle. And from the left ventricle, the blood will come to the right ventricle through the ventricular septal defect. So this diagram is very clearly highlighting the role of the ASD and the VSD in maintaining the circulation in tricuspid atresia. So whenever there is a restriction of the atrial septum or the VSD, then the flow of the blood out from these hearts will be compromised. This is a 4D rendering in tricuspid atresia showing a small right ventricular cavity with good sized LV. Another picture of the same. The tricuspid valve atretic, and that is shown by the arrow, and we can see the ventricular septal defect. Both these hearts are showing a large unrestricted foramen ovale. Now we come to the next group of conditions, which is the septal defects and abnormalities of the cardiac crux. In this group of anomalies, the most important would be AV septal defects. The primum ASDs and the common atriums are a part of the spectrum. It is important to say that we cannot diagnose secondum ASD in utero because normally there is a foramen ovale, and it is often difficult to differentiate an abnormal secondum ASD from foramen ovale. Ventricular septal defects are very commonly found in fetal scans, particularly muscular VSDs, and most of these are benign. Now we will discuss the phenomenon of reverse offsetting in corrected transposition with the help of an illustration, and we also will see the differential diagnosis of abnormal coronary sinus. Atrioventricular septal defects are one of the most common abnormalities of the fetal heart. So this movie is showing the classical example of complete AV septal defect. We can see that the four chambers of the heart are intact, but there is a defect in the center of the heart. The first feature of the AV septal defect is a large defect in the crux of the heart, which we can see in the movie and illustrated in this picture very nicely. The defect is better appreciated in the diastolic frame with the valve's open position. And then we see a defect in the center of the heart as shown by the star. The second feature is the loss of offsetting. So this is an example of a normal heart, and this is an example of AV septal defect. And we use a systolic frame to evaluate the offsetting. So in the normal heart, we see that there is a differential insertion of the AV valve leaflets. The tricuspid leaflet will have a lower insertion, and the mitral leaflet will have a higher insertion. In AV septal defect, there is no such offsetting. Both the leaflets will be at the same level. As illustrated, it's a straight line insertion. And this should be evaluated in the systolic frame. The loss of offsetting here is demonstrated with the tricuspid valve is at the lower level and mitral is at a higher, while in AVSD we see the same level insertion. The third feature is the alteration in the atrioventricular length ratio. So in the normal heart, the atria is slightly shorter and the ventricles are longer. So the AV length ratio will be less than 0.5. In the AV septal defects, the ventricles are shorter because the AV valve annulus is at the lower level and the atria get elongated. So there will be an increase in the atrioventricular length ratio in AV septal defect. The final feature is in color flow mapping. So here we see color flow, and we can see that the normal red flow, which is from atria to ventricle, but here you can see a bit of blue flow suggesting AV valve regurgitation. And when we use the still frame, we see a very characteristic feature, which is there will be a single channel of blood flow to ventricles and diastole instead of the normal two channels across the two AV valves. So the three important features of AV septal defect are the loss of offsetting in systolic frame, the large defect in the center of the heart in the diastolic frame, AV valve regurgitation, and the alteration in the AV length ratio. This is a variant of AV septal defect called the common atrium, where you see that there is no atrial septum at all. It's a single atrium. Another variant of AV septal defect where there is one AV valve, but when you look at the ventricles, you see in this case that the right ventricle is quite large, while the left ventricle is hyperplastic. Most of the blood from the atria is going to the right ventricle as shown by the bold arrow, while the inflow to the left ventricle is considerably diminished. This is nicely demonstrated in this 4D rendered picture. We can see that the right-sided ventricle is quite prominent, while the left ventricle is small, and most of the blood is going to the RV and very less to the LV. So this is referred to as the unbalanced AV septal defect. And this unbalanced AV septal defect is quite an important finding in right isomerism. We saw that the first clue for right isomerism comes from the abdominal situs, where there is a juxtaposition of the IVC and the aorta on the same side of the spine. The characteristic abnormality in the intracardiac anatomy of the right isomerism is unbalanced AV septal defect. These anomalies have further variations in the cardiac anatomy, including abnormal relationship of outflow tracts, pulmonary stenosis, anomalous pulmonary vein drainage, and so on. Now let us look at the coronary sinus. So this may give a clue to other structural anomalies. So this is a normal coronary sinus, and typically it is seen just above the left AV valve. Here the arrow is pointing towards the coronary sinus. It's a very small structure normally. The coronary sinus is imaged by a posterior tilt from the four-chamber view towards the abdominal situs. Now in this case, we can see that the coronary sinus is quite considerably dilated. And here in the four-chamber view, we can see that round structure lateral to the left ventricular inflow, and that's the dilated coronary sinus. So the dilated coronary sinus usually is associated with two abnormalities. One is persistent left SVC. It is usually a benign variant. But if there is no persistent left SVC in association with the dilated coronary sinus, then we need to think in terms of something else, which is usually a more severe abnormality, that is a cardiac type of total anomalous pulmonary venous connection, draining to the coronary sinus. Now we come to this very important condition which can be suspected by the four-chamber view, that is congenitally corrected transposition of great arteries. Here there is a variation in the offsetting pattern which is referred to as reverse offsetting. So this is a normal heart. We see the right and the left here, and this is the heart four-chamber view in corrected transposition. We can see the right and the left. So let us analyze these two four-chamber views. First, let us look at the moderator band. In the normal heart, the moderator band and hence the right ventricle is on the right side. While in corrected transposition, we see the moderator band on the left side. That means that the ventricle which is seen on the left side is the right ventricle. Let us now ensure the atrial anatomy. So in the normal heart, the left atrium is receiving the pulmonary veins, and that is seen on the left side. So what is happening in corrected TGA? The left-sided atrium is indeed receiving the pulmonary veins here, and we can see it in color flow. So in CCTGA also, the left atrium is left-sided, but the ventricular morphology is different. So in the normal heart, the tricuspid valve, which goes to the right ventricle, is having a lower insertion, while in corrected transposition, the left-sided valve is having a lower insertion. So that is the morphological tricuspid valve. Hence, the anatomy of corrected transposition is that the atrial morphology is same. The left atrium is left-sided, and the pulmonary veins enter the left-sided atrium. Then there is atrioventricular discordance. The left atrium connects to the right ventricle, and the left-sided AV valve is at the lower level. So that is the tricuspid valve. The right atrium connects to the left ventricle, and the right-sided AV valve is inserting at a higher level. So that's the morphological mitral valve. So by a careful analysis of the four-chamber view for looking at this phenomenon of reverse offsetting, a valuable clue to the diagnosis of corrected transposition of great arteries can be obtained. Further up in CCTGA, there will be abnormality of the outflow, with the left ventricle giving rise to PA and the right ventricle giving rise to the aorta. Many a time, CCTGA, just by the evaluation of outflows, is wrongly interpreted as complete transposition. So if you come
by a careful analysis,
the correct diagnosis of this condition will be obtained. Now looking at some examples of ventricular septal defects. So this is one case where you see a defect in the ventricular septum just below the valve. This is called the inlet VSD. Very often this is found as a combination of AV septal defect. This is an example of a tiny muscular VSD, which is seen in the middle of the septum. So it's called a mid-muscular VSD. So this is a VSD which is located in the apical muscular septum. Now we see another VSD in the LVOT just below the aortic valve. So this is perimembranous VSD. In this movie, I am showing a mid-muscular VSD with color flow, and we will notice that there is color flow in both directions. It's called a bidirectional shunt, which is very typical in the fetus. Now, most of these muscular VSDs are very benign conditions, and most of them have a very favorable prognosis. Most of them close by themselves. Other forms of VSDs like large perimembranous VSDs, inlet VSDs will require surgery, but generally the prognosis is excellent with VSD. Now, some examples of VSD which is rendered using the 4D rendering technique. This is an apical VSD. The second picture is showing as a red dot a VSD in the apical portion of the ventricular septum, which is seen from the RV side. So this B is showing the mid-muscular VSD. The normal image is shown the first two, and the third picture on the right is showing the mid-muscular VSD. The ventricular septum is profiled en face from the RV side, and we see the blue dot in the center, that is a VSD. And here we see a perimembranous VSD en face from the right ventricular surface. The aorta is shown by AO and PA is seen as PA, and we can see that there is a black dot just below the aorta, which is a subaortic or perimembranous VSD. Now this is another example where we see that the ventricular septum is completely absent. There is no septum whatsoever. Both the mitral and the tricuspid inflows are going into this single common ventricle, as we can see in this picture. So in this condition, we can not label this as a large VSD, but rather we call it a single ventricle of the left ventricular type, because the entire left ventricular septum is absent. So this is not a VSD, but rather this is a single ventricle. Now we will cover the intracavitary lesions, and one set of lesions are the cardiac tumors. So this is showing an example of multiple cardiac tumors in both the atria and the ventricles. You will notice that these tumors are of quite hyperechoic also. These are classically rhabdomyomas, and they are associated with a genetic condition called tuberous sclerosis. So this is a large solitary tumor inside the right ventricular cavity, which is completely occupying the RV cavity. And the solitary tumors are typically myxomas or fibromas. Now, 4D rendering of tumors. This is a tumor which is seen on the surface of the heart, on the pericardial surface. It's a large tumor, and this is an example of a pericardial teratoma. This is often associated with significant pericardial effusions also. Now we see multiple tumors. The left-sided tumor is seen on the mitral valve, and it seems to be completely blocking the left ventricular inflow. The right-sided tumor is seen towards the apex of the right ventricle, and this is an example of rhabdomyomas with a tumor blocking the LV inflow. So this is a large fibroma which I showed in the previous slide in 4D rendering, and this tumor is totally occupying the RV cavity. It's a solitary tumor. Now these are rare abnormalities, the cardiac diverticulum. Here we see a large diverticulum shown by the letter D arising from the right atrium, RA. And that is rendered. We can see a large communication between the RA and the diverticulum. This is another diverticulum arising from the left ventricle here, and shown by rendering. The native left ventricular cavity is rather small, while the diverticulum shown by D is very large. The arrow is pointing towards the neck of the diverticulum, which is connecting with the left ventricle. The third example is the diverticulum from the RV. The D is denoting the diverticulum, and this is the 4D rendering of the same picture. So the importance of the cardiac diverticulum is that it often can cause secondary problems like rhythm abnormalities, Sometimes there could be clot formation inside the diverticulum. Most of them, particularly the right atrial and the right ventricular diverticulum, tend to be hemodynamically stable, while some diverticula involving the left ventricle can cause significant congestive heart failure in the postnatal period. Now, this is one of the most common variations in the four-chamber view, for which a large number of referrals can happen, including to fetal cardiology programs. This is the echogenic intracardiac focus. This is a solitary focus seen in the LV. Sometimes we can see bilateral echogenic foci. Now, this is a totally benign condition, and from the cardiologist's perspective, this has got no significance. However, this is considered to be a soft marker for genetic anomalies. This study looked at the second trimester markers for trisomy 21, published in the Ultrasound in Obstetrics and Gynecology in 2013. As an isolated marker, the intracardiac echogenic focus had lower significance. The risk was less than 1. Other features like ventriculomegaly, abnormal nuchal translucency, aberrant right subclavian artery, absent or hyperplastic nasal bone were more robust and significant markers compared to the echogenic intracardiac focus. Now, our policy for these lesions is that we reassure the patient from the cardiology perspective, but we recommend a detailed survey for other markers, and if these are present, according to the fetal medicine consultant, further evaluation may be done. Now, let us look for the lesions in the area around the heart, where we look for pericardial and pleural effusions. So this is showing a normal four-chamber view of the heart, but there is a significant fluid collection around the heart. Here, the heart contractility is good. There is no pericardial effusion, but there is massive pleural effusion. Pleural and pericardial effusion can be a sign of hydrops fetalis, fluid collection in different parts of the fetal body. Some of the cardiac causes of these include severe valve regurgitation, rhythm problems, both tachycardia and bradycardia, high output heart failure, which can occur in anemia, or teratoma, or certain systemic arteriovenous fistulas. But whenever there is hydrops fetalis, we should look for causes outside the heart as well. Now, the four-chamber view often gives us a first clue towards the diagnosis of cardiac rhythm problems. So this is one example where we can see very obviously that the heart rate is very fast. So that is tachycardia. In the second example, we can see the opposite end of the spectrum, where there is significant slowing of the heart rate. And that is bradycardia, and in this case, it is due to heart block. This is the third example where there is overall slow heart rate, but there is an irregular heart rate due to ectopic beats. Obviously, we cannot confirm the diagnosis of arrhythmias by just the four-chamber view. It needs a detailed assessment, which we will be seeing in my final lecture of the series. However, the four-chamber view gives a first clue. And in the four-chamber view, we can also look for evidence of decompensation like cardiac dysfunction, pericardial effusion, and so on. Now, eyeballing assessment of the cardiac function. So in the normal heart, we can see that there is a nice contractility of the heart. There is no fluid collection. While in ventricular dysfunction, it is very obvious that the contractility is significantly diminished, as we can see from this movie. Now, I would like to emphasize the fact that for the evaluation of cardiac function, always rely on movie clips, because we need to see the contractility. So never take still pictures alone. So in the assessment and when you record your images, please remember to record at least one good movie clip of the four-chamber view, both in grayscale as well as in color flow mapping. Whenever there is ventricular dysfunction, then we should go on to the further methods to assess the ventricular function in detail. Now, this is an example of critical aortic stenosis, and I showed this in the first few slides. Here we see that the right ventricle is contracting well, while the dysfunction seems to be confined more towards the LV. This is really illustrated in this movie which I'm running now. It's a short axis view of the ventricles. The right ventricular free wall is contracting very well, while the left ventricle appears to be contracting very less. So whenever there is a selective ventricular dysfunction, we should look for the possibility of an outflow obstruction. So if it is a left ventricular dysfunction, suspect aortic stenosis. If it's a right ventricular dysfunction, suspect pulmonary stenosis. Now, the last part of our discussion, we shall focus on the area behind the heart. So this is a normal heart in which in the area behind the heart, that is behind the left atrium, we see only the descending aorta. So the only structure behind the left atrium is and the spine is the descending aorta. We can also see the pulmonary veins joining the left atrium. In this picture, we can see that the left atrium appears abnormal. There is nothing seems to be entering the left atrium. So the left atrium appears to be bald. When on a closer look, we see that there is something like a channel between the left atrium and the descending aorta. On the color flow mapping, as we can see in this picture, we see that there is something draining into the channel, and these are the pulmonary veins. And then on tracing this channel, we see that this channel is draining most superiorly towards the brachiocephalic vein and the SVC. Thus, a very close evaluation of the area behind the heart resulted in the observation of this abnormal channel between the left atrium and the descending aorta, and on a much more robust evaluation with color flow mapping, we could trace the pulmonary veins into the channel. So this is the diagnosis of a supracardiac TAPVC draining to the SVC. Hence, this clue completely came from the evaluation of the area behind the heart. Another feature, another abnormality of the area behind the heart is the double vessel sign, which we saw in the discussion on the abdominal situs. So in the four-chamber view here, we can see that between the left atrium and the spine, we see this sign, the double vessel sign. Normally, you find only one single black dot, which is a descending aorta. But here we see two. And the second one, which is posterior, is the dilated azygos vein. Here, the pathology is that the inferior vena cava is interrupted. So on the bicaval view, you see only the SVC, the IVC is missing. When we look at the sagittal view of the aortic arch in the second picture, we see that posterior to the aortic arch, there is another vessel, which is a dilated azygos vein. And when we put color flow mapping, we see that the azygos vein, which is shown by the red, is draining towards the heart, towards the SVC. So this is the diagnosis of interrupted IVC with a dilated azygos going to the superior vena cava. So this is an important feature of left isomerism. Left isomerism can have additional features like AV septal defect or rhythm problems in the form of complete heart block. So the isomeric hearts are often complex, and looking at subtle clues on four-chamber view like this enables the diagnosis of these complex variations. To summarize the four-chamber view, the four-chamber view is often considered to be the window to the fetal heart. It is a relatively easy view to perform by all people, and hence it is possible to do this view in all mass screening programs. However, a systematic evaluation of the four-chamber view gives a large number of clues. It gives clues to the diagnosis of a wide spectrum of major and complex heart defects. The four-chamber view also gives a clue to the initial suspicion of cardiac rhythm problems and cardiac function. And from a prognostic point of view, the four-chamber view helps to separate complex heart defects, which can undergo palliative surgery, from correctable heart surgeries, which can be corrected with good outcomes. Most of the complex heart defects which can be palliated have an abnormal four-chamber view characterized by small size or hyperplasia of one or other ventricle, while the correctable heart defects typically have a normal four-chamber view with two good-sized ventricles. We shall discuss the prognostic aspects of the imaging in detail in the fifth lecture of the series. Thank you very much for listening to this lecture, and I look forward to answering some of your questions. Thank you.
Thank you very much, Prof. Balu. Hi everyone. I believe Prof is having is facing a little bit of a technical issue, and he will not be able to answer live questions. Feel free to leave your questions in the box in your window, and we will get Prof to reply these questions via email. We'll leave this question box up for the next 5 minutes.
Hello, can you hear me?
We can hear you.
Hello?
Yes, Prof, we can hear you. Please go ahead and start your webcam.
Yeah, I think I saw one question about the types of VSD. I think in the slides I did show the common types of VSD. In the fetal life, I think the most common type of VSD you would see is the muscular VSD, which is very common, and most of them are very benign. You don't need to do anything, and often it causes a lot of panic, and you say hole in the heart, the family will get very upset. So most of these conditions are self-limiting, and even if they are present during the fetal life, all we need to do is to do an echo after birth and reassure. The larger type of VSD, sometimes like the one which I showed, the membranous VSD or subaortic VSD, or sometimes an inlet VSD which is seen as a part of the AV septal defect. These are the ones which can sometimes will need surgery. But again, VSD has got excellent prognosis, and even if we operate and close the defect, the outcomes are very good. So that's the one question which I saw. Hello, anything? Okay, I think we can close the meeting then.
So much, Prof, for your time.